Hello, everyone. This is Ayman Al-Hindi, professor of OBGYN at the University of Chicago, and it's a pleasure to be with you today. I would like to thank the individuals that made this great conference a reality. I particularly like to thank Ms. Liz Cora from African Fibroid Foundation, Africa, and also our very own Miss Lillian Prince, hopefully soon to be Dr. Lillian Prince. She is our wonderful PhD student for all the effort they put to put this conference together. And of course, I would like to thank Dr. Phyllis Lippert and the Campion Fund for supporting this important event. I'm really excited to participate in this, and I hope this will be a regular annual event so we can continue our collaboration with our colleagues in Africa to try to combat uterine fibroids in Africa and worldwide. The title of my talk today is Natural Compounds for Prevention and Treatment of Uterine Fibroids, and I'm going to focus mostly on green tea extract. These are my disclosures. So the objective of my talk, I'm going to start with some introductory remarks and then just an overview of the treatment of fibroids. And like I said, I've been asked to focus mainly on green tea extract or EGCG, Epigallocatechin, gallate, and uterine fibroids, and we'll finish with some future direction. So in terms of uterine fibroids, I'm sure other speakers would have covered that, but as we know, it's a very common tumor of the wall of the uterus, very common globally, but particularly more prevalent and more severe in women of color. And it has a major negative effect on women's quality of life and a cause of major morbidity and also a lot of surgery, normally or usually in the form of hysterectomy, but also other procedures. We published this paper with Dr. Prosper Igaboli from University of Nigeria a few years ago about the fibroid burden in Africa, all over Africa, but this particular review article focused on sub-Saharan Africa. And this is a picture of one of his patients that he cared for at the University Hospital in Abuja. And as you can see, this was a significant disease burden in this particular patient. The interesting things also I came to know interacting with my colleagues in Africa and actually visiting different hospitals in Africa and Egypt and in other countries, that beside all the clinical manifestation of fibroid, also it has some social impact, because as you can see in this particular patient, who is very thin and with such a big fibroid disease, she had this significant bulge in her abdomen. She actually looks like that she might be pregnant. And in some close communities, if this patient happened to be, let's say, unmarried, this actually might cause a lot of social stigma and additional stress for this patient, beside all the clinical manifestation that we are all familiar with. I also wanted to include this figure about the number of publications related to fibroids from different countries in the world. This is a paper from 2018, so at least up to that point, these are the numbers. And as you can see, overall, the numbers of publication basically reflecting the amount of research done in the area of fibroids is rather limited, but even more impressive that the highest countries publishing these papers, the United States were the highest, and then certain countries in Europe, but unfortunately, very few papers coming out of Africa, which is kind of compressed here in the lower part of the figure. And I hope this conference and other initiatives can change this. I also wanted to impress upon you that fibroids actually started in Africa. This is a picture of a calcified fibroid from an Egyptian mummy about estimated 5,000 years old that was discovered some time ago, but then further analysis of DNA was published more recently in 2017. Just to impress upon you that fibroids started in Africa and also still quite common and almost pandemic level in Africa. And I hope, again, that we can work together to change that. We know from our work and many others that fibroids are more common in women of color all over the world. In the United States, for example, they are much more common in African American compared to European American, and also more common in Hispanic compared to European American. They start early, quite early, in late teen years in women of color, much earlier than their European counterparts, and also continue to significantly increase compared to other ethnic groups. And also the disease burden as far as the number of fibroid, the size of fibroid, and of course, consequently, the number of hysterectomies, for example, are much higher in women of color in general compared to other ethnic groups. We have published this review article just a couple of weeks ago, an endocrine review, trying to dig deeper into why this is, why fibroids are more common in women of color. So because of the time constraint in this conference for my presentation, I'm not going to go into details, but I would really like to invite you to look into this. As we, in this review article, we covered comprehensively the different factors that can be contributing to the health disparity of this disease. So how do we treat uterine fibroids? Generally, I would say like any other disease, we have medical treatment options, surgical treatment options, and then some procedures such as uterine artery embolization or MRI guided focus ultrasound. But unlike other diseases, until recently, the main treatment options that have been actually exercised and established themselves as the mainstay has been surgery, typically in the form of hysterectomy. In the United States, for example, we do more than 600,000 hysterectomies every year. Many of those are due to fibroids. We do also myomectomies and other procedures. But with the recent development of several FDA-approved safe and effective long-term treatment options for fibroid, I'm hoping and speculating that the paradigm will shift towards medical therapy and less on the surgical side, which is a welcome addition and welcome change anywhere in the world. But I would say particularly in low resource countries, this particularly will be an important shift. So what are the medical treatment options against uterine fibroids? Again, for the sake of time, I would not cover every aspect of this, but generally we can divide those into non-hormonal versus hormonal. And non-hormonal are usually natural products, while hormonal in this list are all synthetic products. Our group has contributed significantly to the development of several of these recent hormonal additions, such as elagolix, ursodeoxycholic, linzagolix, and some of this work has been published. So if you're interested in this, I would encourage you to check out these papers in the literature. But for today, I'm going to focus particularly on the utility of green tea extract, or the active ingredient there is called EGCG, Epigallocatechin gallate, for the treatment and hopefully also for the prevention of uterine fibroids. The way actually we got into this many years ago, so about 14, 15 years ago, we were actually trying to understand again why fibroid is more common in women of color. And because we know that fibroids are estrogen progesterone dependent in a way that estrogen and progesterone cooperate to actually enhance the growth of fibroid and make fibroid bigger. We wanted to take a genetic approach and look at genetic polymorphic markers distribution between African-American patient versus European-American patient, as far as different genes and receptors involved in estrogen signaling. So we looked at estrogen receptor alpha, estrogen receptor beta, progesterone receptor, aromatase, which is an enzyme that makes estrogen convert testosterone to estrogen, and then COMT. To make a long story short, we found a significant association between polymorphic markers in ER alpha, estrogen receptor alpha, and COMT, and the different ethnic groups in women suffering from fibroid, but we didn't find association in the other genes. And that's how we got to know about the COMT story. So what is COMT? COMT, the full name is catechol O-methyl transferase. So it's an enzyme involved in the breakdown or the catabolism of estrogen. So this is the forms of estrogen in the human body, mostly in the forms of estradiol, some in the forms of estrone, which is a weak estrogen. Then after the estrogen binds to the receptor and do its work, then like any other compounds in our body, it needs to be broken down or metabolized, if you wish. And the estrogen goes through this cycle. Eventually, it will be methylated using COMT into methoxy products, okay? Now, the estrogen breakdown products or metabolites turn out to be actually hormonally active. They are not inert products. They are actually hormonally active. And in such a way that the methoxy estrogen products are actually quite estrogenic, quite active, actually even more than the natural compound or the parent compound, while the precursors of those are anti-estrogen. So in such a way that the more COMT activity you have, the more estrogenic milieu you will have in this particular cell or in this particular tissue, because you're going to have more of the methoxy metabolite. While vice versa, if you have low COMT activity, you will have more of the anti-estrogenic activity, and the estrogenic milieu in this tissue will be low estrogen or anti-estrogen. So because of that, we were very interested in the polymorphic markers on the COMT gene and its association with different ethnic groups. And sure enough, we found that the high activity, the high enzyme activity allele or genetic marker, the VAL comes from valine. Valine are actually associated with higher COMT activity, and they are much more common in Black individuals or Black women. So that suggests that Black women in their body milieu, particularly in the myometrium, will actually have more estrogenic milieu, which again is consistent with higher risk of developing fibroid. While white or European American women actually had very less frequency of the VAL and more common of the counter allele is called the methionine, which is associated with low estrogenic milieu. So this was all consistent with our understanding of the pathophysiology of fibroid, and we published that several years ago. But this actually got us interested in the COMT gene in general, and what does it do in terms of causing fibroid and enhancing fibroid growth. So we first started with simple stuff about the expression, for example, of COMT in fibroid versus adjacent myometrium. And as you can see here for the immunohistochemistry about the protein expression of the COMT gene, it's much higher in the fibroid compared to adjacent myometrium, suggesting that it is important in the pathophysiology of fibroid. I'm kind of jumping over a lot of data because it's already published, but it turned out that all data suggested that COMT is actually enhancing fibroid growth in such a way that if we can inhibit COMT enzyme activity, we would actually have some benefits in killing fibroid cells and then eventually shrinking fibroid tumor and improving symptoms associated with fibroid. So we start looking for agents or compounds that actually can inhibit the COMT gene. And we found in the pharmacology literature that the EGCG, green tea extracts, are very potent COMT inhibitor. So we were quite excited about this because it's a natural compound, easily available, inexpensive, and then we were also speculating that it would be safe. Most natural compounds are safe to use with limited or no side effect. So we were very excited that there is a natural COMT inhibitor, and we wanted to evaluate it further. So we jumped on this right away. We start to use different COMT inhibitors, the EGCG and other COMT inhibitors in the lab first to see if it actually can inhibit the growth of fibroid cells. And here you actually see that estrogen enhances fibroid growth. This is fibroid cell proliferation, while different forms of COMET inhibitor significantly limit and inhibit fibroid cell growth. That was quite encouraging. We wanted to kind of dig deeper to know exactly how does that work. So we found that the EGCG causes apoptosis or cell death, programmed cell death in fibroid cells. And as you see here in this figure, also it caused some genetic changes. For example, in this case, it decreased the expression of BCL2, which is anti-apoptotic gene, meaning it activates apoptosis, again, enhancing cell death in human fibroid cells. We also did some global genetic profiling for cells treated with EGCG or the green tea extract versus placebo. And we can see that the EGCG actually works through multiple pathways, not only through inhibition of COMT, but also it has very strong anti-inflammatory effect. It also have antioxidative stress effect, etc. So that was all good news and encouraged us to go further. So again, here we characterize the genetic gene changes and expression of different genes after treatment with COMET inhibitor. And we can see that when we add the COMET inhibitor here, genes involved in cell proliferation, such as cyclin D1, are downregulated, meaning the cells are not proliferating as actively. Again, BCL2 and BAX, apoptosis-related genes, are altered in such a way that apoptosis is activated or cell death is activated. So all of this actually encouraged us to go further. And what do you do next? You evaluate then this potential therapeutic agent in animal models. So we tested this first in a nude mice model where you develop a fibroid lesion under the skin. So it's kind of a human-made animal model. And as you can see here in this square, these are the fibroid lesion. And with the group treated with the EGCG show growth arrest and very slow growth versus the placebo, that tumor grow exponential. And here's the numerical results after 4 weeks or 8 weeks, a significant shrinkage of the fibroid in the EGCG treatment group. And here's also additional gene expression of PCNA, which is the gene reflection of cell proliferation. You can see much less cell proliferation in the fibroid in the treatment group with EGCG versus the control group. And this work, again, has been published earlier. Then we wanted to even validate this further into another authentic animal model of fibroids called the ECARAT, where the fibroids spontaneously develop in the animal model. So it's not human-made, it's actually a spontaneous fibroid. So it kind of resembled the human situation more closely. So we tested the ECARAT in a similar fashion. And again, you can see here in the placebo-treated rats, fibroid continued to grow significantly over 4 weeks of treatment, while the group treated with the COMET inhibitor immediately stopped growing and actually gradually shrinking. This again was very encouraging, and this is an example of a tumor before treatment, and then at the end of the treatment 4 weeks later, you can see much significant shrinkage in the ECARAT fibroid treated with green tea extract. So this all really encouraged us to go ahead with a clinical trial that we were very happy and grateful to the NIH for funding this trial a few years ago, where we treated about 80 patients with uterine fibroids, about 40 in the placebo arm and 40 in the green tea arm, where they received 800 milligrams of EGCG orally in these capsules every day. And again, this is published. I would encourage you to go there for the full details. But briefly, we saw a significant improvement in the green tea treated group. For example, here's the fibroid volume. We saw about 33% shrinkage of the fibroid as assessed by ultrasound after about 6 months of treatment with EGCG, while the placebo-treated group actually continued to grow and gained about 24% increase in fibroid volume. Here we looked at the symptom severity using the validated quality of life questionnaire for uterine fibroids. And as you can see here, the green tea treatment group saw significant decrease in the symptom severity, about a decrease of about 25 score points, while the symptom severity actually got worse in the placebo group over the 6 months, and they gained about 7 points in the score, in the symptom severity score. Quality of life, the same way. Quality of life improved about 20 points in the green tea treated group, while it was more or less static or stable in the placebo group by increasing only 2 points. So all of this was very encouraging results. As I said, we followed these patients by transvaginal ultrasound, and this is just an example of a patient with about 3 centimeters by 3 centimeters intramural fibroid here. And you can see here after 6 months of EGCG treatment, the fibroid actually totally gone. So this actually encouraged us, especially as I said, natural products such as EGCG is quite safe and inexpensive. And the safety profile, by the way, the NIH trial we did in 2013 was outstanding. We only had mild gastric irritation, which actually went away when the patient used the EGCG on after a meal, like on full stomach. So basically the safety profile was outstanding. This encouraged us to go into evaluation of this in another group with fibroid, but also infertility. So this is an ongoing study based on the fact that the fibroid decreased fibroid volume, that the EGCG decreased fibroid volume, but specifically it actually changed the secretion profile, the cytokines and the different factors that comes from the fibroid that might negatively affect the endometrium and make the endometrial receptivity unfavorable for embryo implantation. We found that the EGCG is able to inhibit the production of TGF-beta3, tumor growth factor beta-3, that from the fibroid, and from literature, from other groups, TGF-beta3 can actually have negative effects on the endometrium. So the working hypothesis here that the EGCG not only will shrink fibroid, but also will improve the quality of the endometrium and presumably improve the chance of successful embryo implantation. So to check this hypothesis and validate it, we are doing an NIH-funded study in collaboration with other centers, Yale and Hopkins, to evaluate, we call it the FRIEND trial, to evaluate the utility of EGCG for treatment of unexplained infertility in women with fibroid and unexplained infertility. This is an ongoing study. This is the general design, and I'm hoping next time we meet, I'll be able to present some data from this trial. So this is the end of my data slides. I just want to end in terms of future direction by saying that because of these encouraging results, using a simple, inexpensive, and safe natural products such as EGCG, green tea extract, and now we can actually think about the concept of early treatment and also the concept of prevention of uterine fibroid. Because data from our group and others, we actually can predict with good amount of certainty who will have higher risk of developing fibroid. We have genetic markers. Also in other work we did, we published that low level of serum vitamin D is a risk factor for development of fibroid. This work has been validated by many other groups. So we are able to identify patients actually before they develop fibroid, pre-symptomatically, or at least very early in the disease journey. So, so by identifying those patients, I'm hoping using these kind of simple natural products such as EGCG, green tea extract, and also vitamin D. I didn't have time to present data on vitamin D. We can intervene early to prevent the progression of the disease, or even intervene even earlier and prevent the development of disease. So this is my last slide. I would like to thank, of course, the wonderful members of our team who contributed to this work. They are mentioned here on the slide, and our collaborators in the US and elsewhere. and of course, funding by the National Institute of Health. Thank you so much for your listening, and I'm happy to answer any questions.